we're talking about station. Station. Now, if you are excited to find out about station, hit that like button and let me know that you are watching and excited to find out about what station means. Now, I have my props right out of camera frame right here, and for talking about station, we're going to need the pelvis and we're going to need the baby. Okay, so station is a measurement that is done to assess or to quantify where the baby is in relation to the pelvis. So before the baby's head is engaged in the pelvis or the baby drops, you might have heard, has your baby dropped? That means the baby's head engages into the pelvis, so drops into the pelvis. See how the baby's in the pelvis right now? Before that happens, the baby is just floating, and that is a -3, you might hear -4, -3, -4 station. So -3 station up here. As the baby drops down into the pelvis, then we're going to go towards 0. So -3, -2, -1. As the baby is halfway through the pelvis, right at the part of the ischial spines, that is a 0 station. And then as the baby passes through that midway point, then we start to our positives, and we eventually get to a +4 station, +4, and that is baby out of the pelvis. Okay, so baby all the way through. I'm not going to put baby through the pelvis right now because on video it looks so awkward because this pelvis doesn't have any joints and doesn't move. So it's a little bit harder to get this baby through gracefully. So the station has to do with how far the baby drops down through the pelvis. So we've got negative numbers, 0 right at the middle, positive numbers for our station. Now, you might be wondering, I remember when I learned about this, I was wondering, well, how do they know? How can they figure out if the baby, what station the baby is in? So this is another number that they can give you, assessment that can be made during a vaginal exam. So during the vaginal exam, which we have a video on that I will put a link down below. The dilation, so opening of the cervix, is assessed. The thinning, the effacement is assessed, and the station is assessed. So as your provider does the cervical exam, they can feel how low down that baby is. If they touch the baby's head and it floats up, well, the baby's head is not engaged in the pelvis yet. So they can tell at what station baby is at. And again, it's not an exact science. It's really done by feel and by experience of that provider. As they do more and more vaginal exams, then they get a feel of what each station feels like. But they can tell how far down the baby is. And a lot of times, before it is time to push, we see baby up in the -1, -2 range. And then a lot of times we see pushing start right about anywhere from -1, 0, +1 kind of station when pushing begins. And it kind of depends on what the cervix is doing, whether the provider, if it's time to push, if you have an epidural and you don't have a strong urge to push and you might be dilated, your provider might recommend waiting a bit until the baby comes a little bit lower station before active pushing is done. So that kind of depends on your preference and your provider's preference and what they think is best. But sometimes if with an epidural, you might wait until a lower station before the active pushing is done. So 0 station is right there at the midline. Now, it's an interesting number, I think, to know as someone in labor, because sometimes we can see lots of contractions happen without a lot of change in dilation or effacement, but where we'll see change in station. So every time you do get a vaginal exam, or you make the option to go ahead with the vaginal exam, I would ask, what station is my baby, or how low is my baby? Because if you are, say, the same dilation between your first cervical check vaginal exam and your second vaginal exam, if your dilation is the same, but your baby has dropped lower in station, then it's a good feeling that progress has happened. So it's just another number to show us how much closer we are to the birth of the baby and how low the baby is in our pelvis. So station is not talked about as much as dilation or effacement, but it is a super helpful number to know and very interesting. So I encourage you to ask that when you get a vaginal exam and find out how low your baby is and how baby's progressing. Also, we have 50 videos so far from the Big Wheel of Birth, and to make them easier to navigate, we've organized them all into a free course. So you can get into that course. It's called Birth A to Z. Oh, I like this one. Today I have on here denial and sleep. Okay, denial and sleep is what I say are my 2 secret strategies for early labor. Now, when I am talking about denial and sleep, my big disclaimer on this is that I mean for first time birthing people. So if you have had a baby before, once, twice, 3 times, however many times, if you have gone into labor and birthed a baby, then this strategy is not what I am suggesting. This is for our first timers out there. Okay, so that's the important piece of information with this. Now, let's dive into denial and sleep. Early labor can be very long. It can be the vast majority of your labor. So if you took your labor as a string and say this is how long your labor is going to be, right? For most people, the vast majority of it is going to be considered early labor. Now, I have a video on early labor I'll link to, but the technical definition of early labor is when your cervix is 0 centimeters dilated until it reaches 6 centimeters dilated. And that is your early labor. Now, this part is usually fairly long. And what I mean by fairly long is it can be hours upon hours. It can be days. That would be the extreme, but it can be. So it is a long amount of time. And in order to successfully cope during that long amount of time, especially if you are laboring at home for that, which a lot of providers recommend that you labor at home for your early labor phase, and obviously talk to your providers about when they want you to come in and when they want you to, if you're birthing at a hospital or a birth center. But it's usually pretty long. And so my favorite strategy, my first go-to strategy that I recommend as a doula and a childbirth educator is to, first of all, denial. Be in denial that you're in labor, okay? And after you are in denial in labor, then you're gonna sleep. Now, this is, obviously, you're not gonna deny any warning signs. So any of the warning signs that your provider might tell you about, like if you're experiencing a lot of bleeding, if you're experiencing spots in front of your eyes, if you're experiencing anything that feels really abnormal, we are not denying that ever. We are going to seek medical assistance. But if you are having some crampiness and say it's like 10 p.m., you've had a long day at work, you're kind of thinking about going to bed, maybe you're thinking about watching some Netflix, and you have crampiness, and you're thinking, this is it. I think this is it. I think this might be labor. Instead of trying to time contractions or call everyone you know and tell them that you're in labor, or try all these other different positions and stuff, my favorite thing for you to do, especially if it's towards the end of your evening, is to say, I don't really think I'm in labor. That could be, could not be. I don't really think it is. That's the denial part. And then step 2 is to get yourself in bed and go to sleep. because sleeping through that early labor where they're still maybe kind of mild enough that you can snooze in between in the rest phases or before they get really organized into a solid labor pattern, sleeping is really what you want to do. And I like to compare labor to, let's say, a long car ride. Now, my family, we do lots of car rides. We actually just moved from Atlanta to Seattle, and we drove the whole way. Not all at once, we did stop. But imagine you have a long car ride ahead of you, right? And you're not responsible for anything of it. You're the passenger. You're not responsible for the map or the directions or the driving or anything. If you fell asleep and say you slept for like 3-4 hours straight and you missed that much of the long car ride, and your car ride went from 18 hours down to 14 hours because you just slept through all of those 4 hours, that's a good thing, right? You missed nothing. You didn't have to experience the 4 hours of boredom in a car ride with nothing to look at. That's a win. So in early labor, before things get super strong. Now, sometimes people's labor does start super strong, but the vast majority of the time it starts out mild, where you can actually sleep. So denial that you're in labor. So don't start timing things. Don't start doing any of the working yourself up to say, you're in labor. Deny that you're in labor and just rest. Your body should allow you to rest if you can rest. Because if it was real labor, like, you're not going to wake up from a nap and the baby is going to be ready to be pushed out. That's not how it works. That doesn't happen with first timers. Remember that this strategy is for first timers only, that we're going to deny and sleep. So what I like to do, especially if you have a doula, is to give your doula a heads up and say, hey, I'm experiencing some labor. I'm going to go to bed. And I guarantee that they're going to support that decision, because getting rest in is so key. Just think, your body does so much work in labor. It's almost like you're running a marathon, even though you might not be actually even moving. Even if you get an epidural, your body is still working so hard and it needs rest. Rest is so key to be able to be effective in dilating and effacing and pushing and everything. So getting in that rest, getting in that sleep is so key. I actually, as I teach Lamaze classes, I usually give people a lot of strategies, again, first timers, a lot of strategies on how to deal with labor. So we talk about positions, we talk about breathing, visualization, vocalization, and a lot of these strategies you can find that we talked about on the wheel also. But I say that if there's anything you can remember, just one strategy you can remember, it's this one: denial and sleep as the early phase of labor. It's so important. Gosh, you guys can probably tell by the way I'm talking about it how important I think it is. We're talking about OP presentation. So there's a couple things I need to talk about OP presentation. I got them right here outside the camera. I need my pelvis again. Oops. And I need my baby. So OP presentation, if you've never heard of an OP baby, you might have heard of what people sometimes call is a sunny side up baby. So let me know in the comments if you've heard either OP or sunny side up. I want to know. I'm really curious. So what this refers to is the position of the baby as they are coming through your pelvis. And sometimes a baby is even born into the world OP or sunny side up. It's funny because sometimes I'll hear people say, yeah, my mom told me I was born sunny side up, which it's really cute. It's like, oh, that was the terminology instead of OP. Now we call it OP. Occiput posterior is what it stands for. And what it means is that the back of the baby's head is the baby is usually entering the pelvis or traveling through the pelvis with the back of their head up against your spine. So as you can see, through the pelvis. Right here is, oops, dropped my baby, is the spine. So baby's head is up against that spine. And what OP, you think like, well, why does it really matter? Where traditionally, or I shouldn't say traditionally, a more effective way for baby to travel through the pelvis is usually looking to one side, and then they have a series of movements to get them through. But when the back of their head, which is usually the hardest part of their skull, is up against your spine, what it can lead to is a couple things. It can lead to what we call back labor is number one. And let's talk about back labor. So what that means is that in a regular non-OP baby presenting non-back labor, most people feel their contractions low below their belly button, that menstrual type cramp area. And sometimes it can start in the back and kind of wrap around to the front, but really most of their feeling sensation, most of the painful sensation that they feel is below the belly button. So in back labor, when you have back labor, a lot of times you'll feel most of the sensation in your back. And a lot of people experience, whereas, a contraction, you feel the painful sensation during that contraction. The rest is usually fairly restful, not a lot of sensation. With back labor, a lot of people in that rest are still feeling discomfort in their back. And so they're not necessarily getting a full rest because that back discomfort. A lot of people with the OP presenting babies will say they feel sort of a grinding in their back, a lot of pressure on their back. So that can be definitely a challenge for people. So an OP presenting baby can possibly cause back labor. Also, we have found that the traditional labor patterns that happen with early labor, active labor, and transition labor sometimes don't look the same when we see an OP baby. With OP presenting babies, sometimes we will see contractions that are closer together earlier in our labor, and they are shorter. The actual contraction is a shorter contraction. So maybe the traditional active or early labor might be 5 minutes apart, lasting a minute. For an OP baby, people in early labor, they might be experiencing contractions that are, say, 3 minutes apart, but only 20, 25, 30 seconds. So sometimes the labor pattern can look a little funky with an OP baby. Also, when we have an OP presentation, sometimes the baby takes longer to descend through the pelvis because of the shape of the pelvis with the baby's head just isn't the easiest one to maximize or to make use of the way the pelvis is designed for the baby to fit. So sometimes we see a slower progress with an OP baby, both the baby's station as the baby descends through the pelvis, or with dilation and effacement of the cervix with an OP baby. Sometimes that can be slower as well. So having baby in that presentation, the last thing as we are working on pushing, the baby's fontanelles or soft spots are designed so that as the baby comes down through the pelvis, the baby's head molds. And molding meaning it changes shape a little bit just so that it can move through the pelvis and the birth canal and out into the world. So it's designed to mold and shape that way. If the baby, so imagine baby's coming down, molding, shaping. If the baby is presenting OP, the molding is not necessarily the same or as effective. And so generally the pushing phase can be more difficult and slower and harder for a baby that's OP. So there are some challenges for sure if if your baby is presenting OP or sunny side up, though it does not mean that it is an automatic reason for a cesarean. There are definitely people that have pushed a baby out OP. We just might find that the norms of labor and the traditional sort of passage through labor is the same as when we have an OP baby. And certainly with the challenges of back labor might also make labor a little bit different and a little bit challenging. So there has been an increase in research and emphasis on OP babies, how to try to convince them to turn when we're in labor, how to successfully manage the painful sensations of back labor. Okay, this is a big one. We are talking about dilation. So dilation is a word that we hear about all the time when we talk about labor, how we're progressing in labor, and it's all about the cervix. So we did talk about another change to the cervix, and that is the thinning, which is the effacement, and it's a video here that I'll put a link down below. Okay, so the cervix is the bottom of the uterus. The uterus is a big muscle, the cervix is at the bottom. It's where our outlet of the cervix is, our exit of the cervix. And when we are pregnant, before we go into labor, our cervix is closed, it's thick, and it's also positioned towards our back. It is set up totally to keep infection out, to keep the baby in, to be as a safe of an environment for the baby as our body can. And so what happens is the cervix has to make a big change in order to allow the baby to come out. So two of the big things that it needs to do is open, which is dilation, and thin, which is effacement. So our cervix has to open in order for the baby to come out. Now, the opening of the cervix is called dilation, and it is measured, or it's measured in centimeters. And so at 0 centimeters would be no dilation at all, so as closed as can be, and 10 centimeters would be full dilation. So 10 centimeters is going to be we're totally dilated, and that's our goal in labor, that we get 10 centimeters dilated. Now, you might be wondering, how do they know exactly how many centimeters dilated you are? Well, it's done through a vaginal exam. We put more into that topic in this video, linked down below. So it's done through a manual exam where your provider puts their two fingers, one finger into your vagina, and basically goes like this to try to find the edges of your cervix to see how open it is. So it's not an exact science, but providers get good at estimating exactly how dilated you are by how much cervix they can feel, how much the baby's head they can feel. Now, your dilation also can show you which phase of labor you're in that first phase. In the first stage of labor, there's different phases. There's early labor, active labor, and transition. So if we want to talk about dilation as it matches those, early labor is our 0 dilated, 0 centimeters, all the way until we hit 6 centimeters dilated. And this has changed if you are watching this and maybe you had a baby years ago, it's been a while, or maybe you're reading old pregnancy books, old books about labor and birth. You might see 4 centimeters is the beginning of active labor, but that has been changed by the American College of OBGYNs, ACOG, and early labor is now defined as 0 centimeters to 6 centimeters dilated, your cervix open. Then from 6 to 8 is what we call active labor, And then from 8 to 10 is the phase called transition. And we have links for all of those stages of labor or phases of labor down below as well. So as our uterus is contracting, the role of the contraction of this uterine muscle is to pull open the cervix and to thin it out. So in order to dilate, you usually need to have some significant contractions. Now, it can be possible that you go to your provider and maybe they do a vaginal exam in the office and they say, oh, you're already a fingertip dilated, 1 centimeter dilated, 2 centimeters dilated. Sometimes that happens before labor starts. But just know that it's not necessarily a prediction that labor is going to continue immediately or anytime soon. So if your dilation is checked, say at your 39-week appointment at your care provider's office, and they say, oh, you're a centimeter dilated and you're 80% effaced, you probably will go into labor soon. That's not necessarily true. And most providers don't make any predictions like that because it could be still a lot more time or it could be when you leave the office. It really tells you not much about predicting when your labor is really going to kick in. The other side is also true that if you had a vaginal exam, they check your cervix and you're 0 centimeters dilated, it doesn't mean that you're still going to have tons of time. That people have gone into labor within hours of being checked at 0 centimeters dilated. So when we get a cervical check and they tell us dilation, it gives us a little information about where we are as far as which of those phases of labor we're in, and it tells us how far we've gone, but doesn't necessarily tell us how much longer it's going to be until we reach fully, completely dilated. So take that information with a grain of salt. I like to say to childbirth ed and doula students that there's lots of factors that go into preparing your body for that pushing phase, and it's not just all related to dilation. We also have that effacement, the station of the baby dropping down. So it's information to know, but not information necessarily that tells you every single thing about how things are going to go, how long it's going to be, or what's next. Okay, today we are talking about contraction monitors. Awesome. So we've been spinning the wheel for a while and we have covered the topic of contractions a couple of different ways. So we have a video I'd love for you to check out after this one on contractions, and then a second one about timing contractions with some special information about using a contraction timer app, which is this video. And check those out after this one is over. But contraction monitors today, I'd love to dive into how those work and the expectations of how you will be monitored when you are in labor. So the first thing is, it depends on your care provider, your circumstance, and where you're giving birth as to how your contractions will be monitored when you're in labor. So let's kind of start and just talk about briefly a home birth situation. And in a home birth, contractions are generally not monitored besides, or I should say electronically monitored. They are monitored just by sight, observing you in labor. And then as you have a contraction, they're probably timed, and they're noted. So that would be the least type of monitoring. And then a birth center is sometimes in between, where they might do more just manual monitoring with a stopwatch or a contraction monitor as on their phone, contraction app on their phone, and then might end up doing some contraction monitoring with our electronic monitors, where I'm going to go into in just a minute. And then at a hospital birth, it really depends on the care provider on how often you are monitored. But I would say if you are monitored intermittently, so if you have a low risk birth, you don't have any drugs in your system, you're not being induced, nothing hooked up on the IV, likely you will have your contractions monitored using, along with your baby monitored, about 20 minutes out of every hour if you are under a intermittent monitoring schedule. And that would be for low risk. Again, no drugs in your system, nothing going on like that. And then if you are being induced, being given Pitocin, augmentation, or have had any kind of IV narcotics, any kind of drugs in your system, or if you have an epidural, then you would have continuous contraction monitor and continuous fetal monitors. So you might have seen pictures of this too as well. And what it is, there are two types of contraction monitors. The one that's used most, and most people have experience with when they give birth, is an external contraction monitor. So it's about this big, and it is made of plastic. It is put on a stretchy elastic belt that goes around your waist, and then is usually put fairly high up on your belly, up on the top, which is called the top of the fundus of your uterus. And that is an external pressure monitor, where as the muscle tightens, the contraction monitor notices that tightening. And then if you see the screen on the monitor, you'll generally see the contractions look like waves as they go from low to high to low again. And those external monitors, the main thing I want partners to know about them is that if you see the screen and you're seeing those contractions go like this, they're not very accurate as far as how high they are, the intensity. So your partner might be experiencing a really strong contraction, but the contraction monitor only makes a little tiny hill. And so try not to pay attention to how high they are when it's the external contraction monitor. Now, it does give you a good idea of how often they're coming, and sort of the start and the stop. And I found a lot of people say that it brings a lot of comfort to them to see them on the monitor. But then the other thing I've heard is, especially if there's no epidural going on and your partner is really having to work through them, then looking at the monitor can be distracting. And it's better just to look and help out the person that's going through laboring person. So it has kind of we've seen it both ways on whether it's helpful or not helpful. But contraction monitors, that's the external monitor. There is an internal contraction monitor, and what it looks like is almost like a straw that goes, you have your cervix has to be dilated, and it goes up into your cervix and just basically slides around the baby. It doesn't hurt the baby. It's very flexible, very bendable. And it is an internal pressure catheter, and it is more accurate as far as the intensity of the contractions because it's inside your uterus. So it really can more accurately give an idea of how strong the contractions are. So most care providers use that external monitor that just sits right on your belly. But if your care provider is needing to know a little bit more about how strong your contractions are, if it seems like progress isn't being made in relation to how strong you're feeling them, maybe your cervix isn't dilating at the speed that they feel like it should be, and maybe they're trying to make a decision between adding some Pitocin to augment it. And we do have a video on Pitocin that I'll put here, but maybe they're trying to make that decision. They might suggest an internal contraction monitor, and it's also called an IUPC, intrauterine pressure catheter. So both of those are options for monitoring contractions when you are in labor. And of course, when you're at home, you can monitor them with the contraction app. So let's see, we've got something called Pitocin. So Pitocin is a form of artificial oxytocin. So just let me take a quick aside and talk about oxytocin. Oxytocin is the hormone in our body that causes contractions. Sometimes you hear it called the love hormone because it's released really in settings where we feel affectionate, where we are having close physical moments with our loved ones. And it's also the hormone that controls and regulates contractions of the uterus. So what happens in labor is oxytocin is produced, and it usually is increased. One way that the oxytocin increases in our body is as the cervix dilates. The dilation of the cervix can increase production of and transmittance of oxytocin. So oxytocin is a really important hormone to keep labor going. Now, Pitocin was created as an artificial version of oxytocin. So Pitocin is used for a couple different reasons in regards to childbirth. So the first one would be to induce labor. So Pitocin, when it is used to induce labor, it is diluted with regular IV fluids. So it is delivered in a bag of fluids, and it's delivered via IV. And the way that care providers use Pitocin is it's it is delivered in a method that's called, it's titrated for us. So what that means, if you ever had any science class or chem class in college, you might have heard that word titration. But what it is it's giving the Pitocin in small amounts and increasing the dosage until it has the desired effects on our body. And so it really depends on your care provider on what kind of contraction pattern they are hoping for as far as increasing that Pitocin. But generally it is increased about every 30 minutes or so. Again, this really depends on your care provider and your circumstance. But it starts out at a low dose and it's increased. And when you are on Pitocin, when your body's getting Pitocin, the fetal heart rate monitor and contraction monitor are definitely watched closely to make sure that the baby's tolerating the Pitocin, the artificial oxytocin, and that the contractions are at a place that they want them, a pattern that they want. And then once your body picks up on the Pitocin and labor is induced, a lot of times they stop increasing it because they found the level of Pitocin that's just right. Now sometimes as labor goes on, they might have to do some adjustments up or down depending upon what's going on. So that is one way that Pitocin is used during childbirth. The other way is similar, also delivered via IV, and that would be to augment labor. So if you go into labor on your own, unlike the induction where your labor is starting, but with augmentation is when your care providers would give you Pitocin to make your contractions either stronger, closer together, or longer, or more effective. So that would be a labor maybe that's not building up and strengthening and having the same amount of change on your cervix. A lot of times this is done if labor has been kind of slowed down as a result of getting an epidural. Sometimes getting an epidural can slow down labor, and then Pitocin is given to augment a labor that was already there. Again, it's also added in a slow fashion and increased until the perfect contraction pattern is found. So a second way Pitocin is used. A third way that Pitocin can be used in regards to labor is after the birth of the baby and after the placenta is delivered. Many care providers will give postpartum Pitocin, so put Pitocin after the birth, and that is as a preventative measure to prevent postpartum hemorrhage and to help your uterus clamp down over that open wound where your placenta was. The uterus has to clamp down and control bleeding that way. And so postpartum hemorrhage, some care providers will give that via IV as well in order to prevent that or to try and prevent that from happening. Like I said, it's really your circumstance and your care provider, how and when, if you have options on whether or not those are used, whether you have options to induce, how to induce, if you have options to augment your labor, or if you're going to need postpartum Pitocin. The fourth way that Pitocin can be used is also postpartum, and it's also the same role as the IV Pitocin in order to help your uterus clamp down, and this would be Pitocin given via shot, which is called IN, intramuscular Pitocin, and it's delivered usually in your thigh into a muscle, and that is the purpose of it, to help your uterus clamp down and prevent that postpartum bleeding, postpartum hemorrhage. So Pitocin is an artificial oxytocin. There are a few ways that it's used in labor, and I hope that you found this helpful.